Good morning. My name is Elise DeVore Berlin, and I am so excited to be with you right now. I'm going to present a brief talk entitled Pills, Patch, and Rings, Oh My, a Practical Guide to Managing Combination Hormonal Contraceptive Use in Adolescents. I do have some disclosures. I have the following financial relationships to disclose. I do receive research support from Merck to my institution. I'm a consultant for Merck and Bayer, and I'm also a Merck Nexplanon clinical trainer. The goals and objectives of this talk are, at the completion of this session, you should be able to evaluate patient concerns about combination hormonal contraceptive use and manage common side effects related to combination hormonal contraceptive use. What I really want to do today is demystify prescribing combination hormonal contraceptives. And I really want you to walk away from this just having a couple more tools in your toolkit for taking care of your adolescent patients. We're not going to review many other issues related to prescribing, including contraceptive counseling, when to start contraceptives, how to be sure a woman isn't pregnant, and long-acting reversible contraceptives. I'm giving another talk during this session where we will review that content. What I really wanted to talk to you today is kind of specific tools and practice pearls around managing combination hormonal contraceptives. I have been in practice doing adolescent medicine for about 14 years now, and I use combination hormonal contraceptives all the time, and I just really wanted to share some pointers and tips with you. So the roadmap for today's talk is that we are going to discuss indications for combination hormonal contraceptive use. We are going to review available products and formulations. We're going to discuss common patient concerns. We will also talk about a couple miscellaneous topics, including extended use. And at the back end of the slide deck for your review, we do have some resources that are listed that I think are pretty great. All right, so the first thing really to talk about is really the vast therapeutic benefits of combination hormonal contraceptive use. A lot of us think about combination hormonal contraceptives as birth control, and arguably that is their primary indication, but for women and girls, there are myriad other benefits that I wanted to review for you. And in practice, probably the most of the time that I am prescribing combination hormonal contraceptives, it is actually not for the primary indication of contraception, but really for these other issues. So just to kind of talk about them. So certainly contraceptives using birth control for contraception is the primary reason. However, they are really excellent and indicated for the management of irregular periods, heavy periods, anemia. They have benefits to menstrual cramps, dysmenorrhea. They are absolutely considered the standard of care for people with polycystic ovary syndrome. They are great at suppressing ovulation and reducing the kind of reoccurrence of functional ovarian cysts. They are good for acne, very good as well for PMS/PMDD, and also for menstrual suppression or management for a variety of reasons. I recently gave a talk with a colleague, and she really talked about women in space and in the military, and really the benefits of menstrual suppression in a variety of industries and scenarios. So hopefully these are some areas that you may feel more comfortable prescribing contraceptives for after this talk if you weren't before. So I think for me the biggest concern I have around contraceptive use really isn't that there's going to be a serious adverse event for users. The incidence of serious adverse events is exceptionally rare. The biggest challenge for combination hormonal contraceptive use has to do with adherence. And this is a great slide that came out of Dr. Behringer's research published in Contraception in 2011. And this slide shows us what the adherence rates are at 1 year for young people ages 14 to 19 using a variety of contraceptive methods. At the time the slide was made, Mirena was the only hormonal IUD, so that is why that is included by name. You can see that Mirena, the copper IUD, and the contraceptive implant have pretty high adherence rates at 1 year, certainly greater than 75%, close to 80%. There are other studies as well that show the continuation rate of LARCs to be possibly closer to 10 or 15%. So, but then once we start looking at shorter active methods, DMPA is Depo-Provera, and you can see that that is about 50% for adolescents. And then pill, patch, ring really do fall off. So pill in between 40 to 50%, patch close to 40%, and ring about 30%. So, you know, my biggest concern around prescribing combination hormonal contraceptives is what can I do to help improve adherence to these methods that certainly are used for contraception, as well as a variety of indications. This slide, and I can see that the attribution is not visible in the presentation, is from the National Survey of Family Growth, was published in 2002. And the reason I wanted to show you this is that the primary reason for contraceptive discontinuation among adolescents was side effects. So as providers, I think that really does suggest that conversations about side effects, as well as how to maintain open channels of communication, are really, really important. And what we're going to do during a fair part of this talk is to talk about how to communicate and manage side effects. So going back to the beginning, let's talk about what are the key components of combination hormonal contraceptives. The combination in the nomenclature refers to the inclusion of both an estrogen component as well as a progestin. A lot of times you'll hear people calling these progesterone, but it is actually a progestin, and some of these progestins are derivatives of progesterone, and some of them are actually derivatives of testosterone. So as a group, we call them progestins. The estrogen component available in the US tends to be primarily ethinyl estradiol, and the dose available in contemporary pills ranges from 10 micrograms to 50 micrograms in the daily pill. The progestin dose and progestin used varies depending on the pill brand, and there is a nomenclature that has been used over the last 20 or 30 years, which is challenged, but it's still in use, so I'm going to share it with you. The first generation progestins include norethindrone and norethindrone acetate, and these were among the earliest progestins used in pill research and in the first pills. The trade names of pills using norethindrone and norethindrone acetate are Orthonovum, Nikon, Avcon, Femcon FE, and Loestrin FE as examples. Second generation progestins include levonorgestrel and norgestrel, and these tend to be widely used in the United States. Pill names that have levonorgestrel or norgestrel include Nordet, Seasonal or Seasonique, and Low Overall. Third generation progestins include desogestrel and norgestimate. Contraceptives using these progestins include Orthocept, Desogen, Mercet, Cariva, Orthocycline / Sprintec, and NuvaRing. And then finally, there is a new generation that's been called the fourth generation, which includes drospirenone. Pills containing drospirenone include Yasmin and Yaz. If you take a deep dive down this rabbit hole, you will find that these progestins have varying qualities and attributes, including varying degrees of attachment to a variety of biochemical receptors, including androgens, progestin, and estrogen, and mineralocorticoid receptors. I think that's not at all important for you to know, and we'll get to this shortly, but really the main clinical attributes that are important are how effective the method is, as well as the side effects. More information about pills. So you may be aware that there is something called monophasic, biphasic, triphasic, even quadriphasic pills. The phasic generally refers to the progestin component variation in the pills. In general, we tend to recommend use of monophasic pills for adolescents. So that's one of my practice pearls, is to stick to the monophasic pills. The reason is if users miss pills and are advised to double up, etc., it can be a little bit confusing when you have multiple colors of pills in your pill pack, and possibly the patient isn't as aware of when her placebo pills are. Also, I have found that patients do have a little bit more bleeding with the triphasic pills. So we'll talk about this in a moment, but I do recommend just sticking to a monophasic pills. There are also extended cycle pills. So these include Seasonal or Seasonique and the derivative generics. Extended cycle pills that are continuous, that are marketed right now, have 84 active pills in the pill pack and then 7 placebo pills. In the case of Seasonal and its generics, they are actually true placebos. If you're wondering, Seasonique includes 10 microgram ethinyl estradiol pills instead of placebos for the inert pills, the last 7 pills of the 91-day pill pack. And there is a continuous pill that is called Librel that has no placebos or hormone-free pills. This has a very low estrogen dose and is not used very often, but I think this drives home the point that there are a variety of options available and that continuous or extended cycling is really safe to do. And I just wanted to share on the previous slide, I included the trade names as the examples. However, there are multiple generics for all of those, and those are totally acceptable and used as well. So, as I alluded to previously, how do you pick a pill? We're going to talk about that in a moment, but I love this quote from the Spiroff and Darney Clinical Guide to Contraception, which I keep handy in my office. So instead of kind of going down the rabbit hole of the progestin or the estrogen and this and that, really there is no evidence that a particular progestin is better or worse in terms of particular side effects or clinical responses. Thus, hormones should be recognized by their pharmacology, and hormonal contraceptives should be judged by their clinical characteristics, efficacy, side effects, risks, and benefits. So no more rabbit holes. So the patch previously known as Ortho-Evra was discontinued and replaced with a product known as Xulane. And this can be effectively considered the generic of Ortho-Evra. The progestin in this product is norgestromine, which is a derivative of norgestromide, which is the progestin in orthocycline and Sprintec. So it's a familiar progestin. The product is or has a warning that it is less effective in women 90 kilograms and over, so that's something to keep in mind. And the estrogen daily release rate is 20 micrograms, which is low, but because of the pharmacokinetics, there is a concern about increased risk of blood clots on this method. There's some controversy here, and I still do prescribe it, but I certainly counsel my patients about the very small risk of a blood clot on this and all the other combination hormonal contraceptives. There's a new patch available these days called Torla. Torla uses a levonorgestrel progestin and is also used very similarly to the Ortho-Evra or Xulane patch. These patches should be instructed to be placed once a week on a part of the body that isn't the genitals, the face, or the breasts, and then changed weekly. So the product comes packaged with 3 patches in a box. The woman would use a new patch every week, and on the 4th week is her hormone-free interval, and generally she'll have a withdrawal bleed during that week. There is another ring available. So NuvaRing is has been out in the market for a long time. It has a low ethinyl estradiol release rate. The daily release rate is 15 micrograms per day, and it's a really nice product. There is a new product which is called Anovera, which is actually one ring. You can see it here in the diagram that is basically used throughout the year in the same way that the NuvaRing would be used. So the general recommendation would be to insert into the vagina and to keep it there for 3 weeks and to remove for the 4th week as a hormone-free interval. With the NuvaRing product, women need to go and get a new ring every month or 28 days. And with Anovera, it's actually the same ring is used the whole year. It comes with a little case, and so during the hormone-free period, a woman can rinse off the device and put it in a case, and then start using it again the next time she's due for insertion. So those are some nice products to know about, and certainly their use will increase over time. All right, so I think I have shared with you a lot of detailing about combination hormonal contraceptives, and now I want to make it hopefully really easy for you, and I'm going to share my personal prescribing preferences. So what I do, and this is how I train my residents and fellows and students, is to really have a go-to pill. It doesn't matter what it is, but as a general pediatrician, I do recommend having at least one combination hormonal contraceptive that you feel really comfortable with. For me, that pill is Sprintec. And again, Sprintec is a generic of orthocycline. It's been around for a long time. A lot of my patients' moms are really familiar with this already. It is a well-tolerated pill, and the ethinyl estradiol dose in this pill is in the 30 to 35 microgram range. So it's a great pill. I also recommend having a go-to low estrogen pill. This is nice to have if someone is having estrogen-related side effects. These include nausea and breast tenderness. And so in that instance, it's nice to have a lower estrogen pill to switch to. I do prefer using a 24/4 cycle pill. And what this means is it's a pill pack that comes with 24 active pills and then 4 inert pills. I think that this helps control bleeding a little bit better for our adolescent patients with more active pills. The pills I include in this category that I freely use are Yaz and low estrogen 24. So regardless of what it is, I do think it's nice to have a low estrogen pill to go to. For bleeders, and again, these would be patients with heavy menstrual bleeding or other bleeding problems. It's not great to use a low estrogen pill on these patients because the estrogen component is really there to help stabilize the bleeding and reduce the bleeding problems. So I recommend using a pill like Low Overall for bleeders, which has a strong progestin component. This is a 21/7 pill, but it works pretty well. I would also encourage you to be familiar with basic patch and ring prescribing. We've discussed it in the previous slide, and the detailing is not very complicated. All right, so next we're going to go through some cases. These are all patients I've seen, and we'll share them with you. So the first one, Rosa, is a delightful 17-year-old patient that you've taken care of for several years. She is planning on starting college in a month, and she has been on oral contraceptive pills for several years for management of irregular periods. However, even on the medication, she has had periods of oligomenorrhea and heavy extended bleeding. She reports to you that she had unprotected sexual intercourse 8 months ago, which was which was her sexual debut. So you had not been aware of this the last time you'd seen her. And she had stopped taking the birth control pills 2 months ago due to amenorrhea. And she hasn't had a period for 10 months. So at this point in your history taking, you're probably getting a little concerned about what might be going on with her. And again, she's sexually experienced now. She stopped taking the pills, and she has had a long episode of amenorrhea, which is about 10 months. So on exam, a pelvic abdominal mass was palpated to just below the diaphragm, and she had an intrauterine pregnancy, which was estimated at 30 to 32 weeks. And even talking about this patient actually makes me upset, because this was just such a shocking, pretty disastrous situation at the time that we were discussing it. She had been really just ready to go to college, and had all her stuff ready for her dorm room, which didn't happen for her at this time. So this patient was referred for urgent prenatal care. So I wanted to kind of do a dissection of what kind of the issues to me were in this case. So I think there were several challenges and issues with this patient that led to the ultimate outcome of an unintended pregnancy. She had irregular bleeding at baseline, and then she had some irregular bleeding on the pills. It's hard to know exactly what was the relationship of what, but she ended up becoming non-adherent with the pills and also experienced sexual intercourse. She was not alarmed when she had long episodes of amenorrhea because of her history. And she also didn't communicate with me about what she was experiencing. And because of the timing of our visits, I was unaware of what was happening to her. Typical effectiveness with birth control pills in the literature ranges from 91 to 93%. And then when you look at adolescents, the numbers actually go down into the lower to mid 80s. So adherence to combination hormonal contraceptive pills is really, really important. Typical use effectiveness, which takes into consideration adherence, is really different than perfect use in effectiveness. And unintended pregnancies do happen, and often it's due to non-adherence. You know, with my patients, sometimes this is they went on a trip, they went away to camp, they spent the night at a friend's house. Sometimes this is related to problems with the pharmacy, problems with insurance coverage, problems with prescribing. And so, you know, to me, there are a couple key kind of clinical pearls related to the importance of adherence. I do think it's really important to counsel about adherence, to use patient-facing materials that help them understand how to take a pill regularly, to talk to them about how to be reminded to take pills, which could be using an app or using a reminder on their phone. I do everything I can to maintain open lines of communication with my patients, and back to the office staff and or the clinicians. I really want to be clear. They know how to communicate with us via the patient portal or via the phone. It is important to provide information to your patients about what to do if they miss a pill. I provide this as a written patient information and go over the basics, but reference them to look and keep that handout about what to do if they miss a pill. I also would recommend you to consider co-prescribing a levonorgestrel emergency contraceptive, such as Plan B, in the event of non-adherence. Also, again, circling back and letting your patients know that they are encouraged to reach out to you with any questions about availability, use, missing pills, and even emergency contraception, should they have those needs. And if you have any questions here, please jot them down and we'll talk about them during the live Q&A. All right, next patient. This was a patient that I saw with some really excellent resident physician. She's a 17-year-old young woman who presents with a chief complaint of irregular vaginal bleeding for 1 year. Previously, she had normal periods, and she's a healthy young woman. The astute clinician, which was a resident, inquired about medications, and she reported that she had been taking birth control pills and had been on them for about a year. So you've got a young woman who's here complaining of irregular vaginal bleeding and also is on birth control pills. So I'd like you to start formulating in your head what you think could be going on. All right. So this amazing resident asks if she ever misses her pills. And this patient reported that she takes them on the days she has sex. Ah! Also, her lab results became positive for chlamydia. So I wanted to talk about spotting. And for patients who are on birth control pills, the first thing I think about is adherence or missed pills. So it's really important to talk about the specifics of how the patient is taking the pills. As you can see, this resident did an excellent job and established that she was taking them completely incorrectly and taking them only when she had sex. So this was probably a huge contributor to the problem. The other thing that I cannot emphasize more is if a patient is sexually active and she has unexplained bleeding and she's on a contraceptive, it's chlamydia until it's ruled out. And even I have deviated from my prescribed path and thought it was something else. And then it comes back to chlamydia and I'm like, oh, I forgot. But fortunately I did the test, but really this should be in the front of your mind. If someone has a new unexplained bleeding pattern on a contraceptive, got to rule out chlamydia if she's sexually active. Also think about trichomonas as well as gonorrhea, depending on the prevalence where you practice. These latter two may be less prevalent. Another thing to think about just in general with spotting or irregular bleeding on a pill is really that the estrogen dose may be insufficient to keep her endometrium stable. So I tend to not use 20 microgram pills of ethinyl estradiol as my first choice for this reason. And often when I am seeing consultations for irregular bleeding, often they have been prescribed a low dose estrogen pill by their PCP. And in switching to a higher dose pill, such as, again, Sprintec or low overall, we can really dramatically improve their experience with that contraceptive. And finally, it's important to think about a pregnancy in any patient who comes in with spotting. This could be an ectopic pregnancy or an intrauterine pregnancy, and it would be important to rule out a pregnancy if she endorses having been sexually active or if you have a clinical concern about pregnancy. Another case. So Leanne is a 13-year-old with moderate to severe acne, and she had been started several months ago on a low-dose birth control pill for acne treatment. Shortly after starting the pill, she developed worsening depression, anxiety, and suicidal ideation, requiring evaluation in the emergency department. She stopped taking the pill 6 weeks ago, around the time she was seen in the ED, and had noted significant improvement of her depressive symptoms. So that was great, but worsening of her acne after she discontinued the pill. So she's back in your office to talk about these problems. And in this scenario, she was trialed on a different OCP, and after 3 months of follow-up, her acne is much improved and her mood is now euthymic. So we will talk about depressive symptoms and combination hormonal contraceptives next, because that's a really important topic for us to talk about. So this is an example of headlines that your patients and you and their parents and the community will see about birth control pills. So this is really attention grabbing, right? Popping the pill, severe mental health side effects of contraceptive pill revealed in the new BBC documentary. And there are numerous other patient-facing messaging and social media, YouTube, etc., newspapers about the risks of depression, suicide, and birth control pill. There's really almost this conspiracy theory-like belief that hormonal contraceptives cause depression, and then concerns about depressive side effects and mood changes are a common reason for method discontinuation. And then in a survey of physicians in the UK, there was also a pretty prevalent belief that hormonal contraceptives cause depression. However, the evidence suggests that an association between depressive symptoms and contemporary hormonal contraceptives does not exist. And in the handouts, you can see these two great, there's a systematic review and a meta-analysis. And you can see that the evidence really does not support that there is any causal relationship between the two. So the clinical pearl from the previous case is really that if a patient has depressive symptoms on a contraceptive, it is absolutely indicated and recommended to stop that contraceptive if you think there is a timing relationship between the contraceptive use and the depressive symptoms. However, often we do find that the depressive symptoms are related to the specific progestin, and with hormonal contraceptives, you can start another hormonal contraceptive that has a different progestin and observe the patient if she still would like to be on a combination hormonal contraceptive, which is what we did in the previous case. And she did experience relief from her acne, as well as she was fine on the new pill. All right, case 4. A 20-year-old trans male starts a 35 microgram ethinyl estradiol OCP with a 21/7 cycle, meaning he takes it for 21 active days and has a 7-day placebo interval for the treatment of dysmenorrhea. He has never used any type of hormones before, and he has also never had any type of sexual contact. At his 3-month follow-up visit, he complains of frequent spotting since starting the pill, which has gotten better since the first pack. He still has not had any sexual contact. The reason I mention this case is because expectations about bleeding are really important to manage. Bleeding and spotting are common side effects with oral contraceptive pill initiation, and they do improve over time in the vast majority of instances. So the clinical pearls that I would share with you related to this are to manage expectations from the beginning around unscheduled bleeding, spotting, bleeding irregularities being common side effects for the first several months of pill use. I do recommend starting with a 30 to 35 microgram ethinyl estradiol pill when you can do that, and to really maintain open lines of communication with your office staff, with the patient and the office staff or clinician, so that the patient knows that you really do want them to reach out to you if they have any concerns. And then finally, you can switch the pill, certainly if the patient is particularly distressed or requests it, but you can get into a situation of just kind of yo-yoing between pills and just not having the patient stay on the pill long enough to have a natural reduction in that bleeding. So in these instances, most of the time I do recommend that the patient stay on the pill, and the symptoms really do often improve. All right, so I'm going to wrap it up. Troubleshooting. So patient may complain of symptoms related to too much estrogen. These symptoms include nausea, bloating, breast tenderness, could be a sign of increased blood pressure, a new headache, or melasma. In these situations, you may consider going to a lower ethinyl estradiol pill as long as the headache is not a new migraine with aura. Too little estrogen, as we've talked about it, could demonstrate as breakthrough bleeding or spotting. In those instances, you can switch to a higher estrogen pill. And either too much or the wrong progestin can present with androgen symptoms such as acne, body hair concerns, headache, fatigue, and mood changes. In these, you can certainly try another progestin or a tricyclic pill. So there's really some pretty simple changes you can make for the most common patient complaints. So how many months to prescribe and how long can you prescribe for? So really, it is recommended, if you can, to do a 12-month prescription, which is prescribing 13 28-day packs or some version of a prescription to get the patient through 1 year. However, the patient's insurance, depending on where you live, may not cover 12-month prescription or dispensation of pills. In these situations, you may dispense a 3-month supply with 4 refills or longer if the insurance is allowing it. And then following up at 3 months is recommended or suggested to check side effects, adherence, provide any STI testing as needed, and really to maintain open channels of communication. And then I should say at the 3-month follow-up, also checking blood pressure is helpful. For extended cycles, unscheduled bleeding is common, but it does improve over time in most instances. So again, managing expectations is really important. For patients who are annoyed with unscheduled bleeding, they can take a 4-day pill-free holiday during their extended cycle to have really a kind of mini bleed and then restart. It's important that they not do this more than once every 4 weeks. Otherwise, they may compromise the contraceptive efficacy and may just do better on a more traditional monthly pill. Some people also call this a flexible cycle. So this is a little trick that you can do to help improve satisfaction and adherence with the extended cycle. And then some instructions about what to do if the patch falls off. So if it falls off within 24 hours of being applied, then try to reapply it if it's still sticky. If not, put a new patch on. And then if a patient is between 24 and 48 hours of having the patch off, basically they're going to just apply a new patch and then stick to their original patch change day. Emergency contraception is usually not needed, but it can be considered depending on sexual activity, or if the patch came off in the first 3 days of the menstrual cycle or in the last week of the previous pack. Some handy references. So this is my favorite reference. It's free from the CDC. It's the US MEC and SPR guidelines for contraceptive care. This can be found in the Apple App Store or Google Play, and you just search CDC and contraception. And as you see on the slide here, there are just tons of very practical evidence-based guidance available around contraceptive prescribing. So as an example, the screenshot I'm sharing with you shows you that you can look under combination hormonal contraceptives and its doses, and then it tells you exactly what to do. This app also has the medical eligibility criteria to help you assess contraindications to contraceptives. This is that same reference, which is available online. There's also a really handy prescribing guidelines for contraceptive use that I wrote with our accountable care organization, Partners for Kids, and here's the website. OCP Reference is another app, has a small cost with it, but I have found it to be helpful. It lists available contraceptives and what their components are. And then finally, this is my favorite contraception reference. It's just a really slim soft cover book, and it's got a tremendous amount of information about contraceptive use. So there you go. I went over the time a teensy bit. I hope you found this really helpful. Please keep track of questions, comments, thoughts, and bring them to the Q&A session. I can't wait to see you there. Thank you. Bye-bye.